Good morning, everybody, and welcome to the first webinar of the HWA webinar series for 2023. Thanks very much for joining us today. I'd also like to welcome people who are working with me as panelists today, which is Charlotte George and Shannon Corbett, and they're members of our specialist palliative care team here. So welcome to them, and they'll be joining us later in parts of this presentation. I'd also like to mention Kathy and Helena, who are also working behind the scenes to bring this to you this morning. So I'm just going to share my screen so that you can see the slides. Okay, hopefully everyone can now see what we're talking about today, which is delirium in palliative care. And really what we're hoping to do is show you the sorts of cases that we see in palliative care and how they are managed. So yeah, look forward to sharing that with you. We're going to use cases that we have worked with in HWA. And so hopefully that will give you a bit of an eye into how things work for us. Okay, so the first slide I thought I was tempted to put up was where we get the word delirium from. It's actually been around since Roman times. Fan of Latin, so put you through this. The word's coming from deliro, which means to be away from or out of the furrow. So it's kind of, you're not where you're supposed to be. And it's an interesting word, a bit like some of the other words in our medical language has also got a word that's used in lay terms, which often I think is quite confusing for people because they talk about someone being delirious, but not really using the word as we would use it, just as we use the word someone is acutely confused, for example. So how would we actually define that medically? The latest term was under the DSM-5, and we talk about a disturbance in attention or awareness. So people are really unable to actually keep their attention on one thing or ability to retain their focus, and reduced orientation to their surroundings. They might be sort of not quite aware of what's going on, and that might change throughout the day. So I can go and see somebody and they seem fine, and then half an hour, 2 hours later, someone else can go and see them and notice this change. There's usually also a disturbance in cognition, which might be something around their memory or their language or their perception of things, which might be something like a visual hallucination. And also there's got to be evidence that that disturbance is a consequence of a medical condition. So those are the technical terms for what a delirium is. Well, what does that mean we actually see? So somebody's mental state may have changed over a few hours or a few days, and typically occurs alongside a medical problem. So it's a bit like I think of it like a seesaw. You've got your own stability in terms of where things are at. And when a medical problem occurs or two or more things occur, then that balance might become out of line. And things could be worse, symptoms come and go, things can be worse in unfamiliar surroundings, and that might be worse at night, or particularly in hospitals, we've come across that sort of thing, that people's delirium definitely becomes worse in hospital. So as we've said, reduced awareness of your surroundings with poor thinking skills and maybe some behavioral and emotional changes. I decided to put in a few mnemonics just because it reminded me of a long time ago when we had to learn these things. So one of the mnemonics for delirium uses the letters of the word delirium. So we've got drugs, and then obviously for us, benzodiazepines and opiates we're using commonly. So they're the ones that we often see. For the GPs amongst you, it might be more the anti-Parkinsonian drugs or TCAs that you're using. Secondly, and there's some poetic license here, they use 2 E's, so epilepsy or electrolyte imbalance. Probably the most commonly we see is low sodium or high calcium causing delirium. Then we've got allowing for 2 L's, liver failure or low oxygen levels, infection, urinary retention or constipation, intracranial causes, uremia when the kidneys aren't working, and metabolic. So that's one of the mnemonics, and some of you might find other ones more comfortable. This is another one which just uses M words to remind us of what all the causes can be. I guess what we can take from this is there's so many causes of a delirium, so many things that can tip people from a stable mental state into this phase of delirium. So there's lots of things to be thinking about. And cancer in particular, patients that obviously we see quite a significant percentage of people with cancer. And in those patients who are hospitalized with cancer, the rate of delirium has been said to range from 14 to 55%. Certainly it's something I'd say that we see in the community team at least every week, maybe 2 or 3 times a week among our patient population. We serve a population of about 250 patients in the West Auckland community at the moment. So the first poll that I've got today in our traditional way is to ask you what you think is the most common form of delirium. So do you think that that's hyperactive, hypoactive, or a mixed delirium? So you guys are welcome to vote on that. By the way, while you're doing that, don't forget that you are welcome to put questions in the Q&A section, which we all hope to get to by the end of the presentation. And if not, then we'll be able to get to it and get back to you with the answers to those. Okay, so we've got quite a mixed bag here. We've got 38% saying hyperactive, 18% hypoactive, and 44% mixed. So mixed, hyperactive, and hypoactive being the most common. So actually what we find is that mixed, I think people did pretty well there, identifying that as a pretty common one, but hypoactive is much more common than we think. And I think one of the reasons that we find that we don't think that this is the case is that we often find it hard to diagnose, much harder to diagnose than hyperactive, which hits us in the face really when we go around and see that patient. So for our palliative care patients, it's a very frequent complication of their disease or additional medical conditions is distressing, obviously, to patients and their caregivers, can be extremely distressing. And especially when that happens near the end of life, I think people find that very hard, or with an irreversible delirium, to manage. It's often associated with poor prognosis, and also means that it's sometimes very hard to make sure that we're getting support right for that person and their family, because they might find it much more difficult to identify symptoms or accept interventions that we're able to offer them. So it's a challenging complication, which we see often. And really, it's an emergency. It's interesting, I always find it I work in Waitakere Hospital as well, and having worked in Auckland City in palliative care, I think that what we see as an emergency in hospitals tends to be things that we can easily do something about, and something like a heart attack is seen as an emergency, a stroke now is seen as an emergency, but delirium and pain, things that we see more often in our patients, are often not treated in that way. But really, we're trying to reduce the amount of time that person has a delirium. If people do remember a delirium, actually that memory is very traumatic. And you'll find, if you're interested on YouTube, there's a whole range of YouTube clips of people who are remembering their delirium, whether it's hypo or hyperactive delirium, and they're really quite distressed by that memory. Actually, we don't often do a great job, believe it or not. Sometimes that's because we don't recognize it. We don't manage it always well. We don't always look for more than one cause, where often that is the case. So there's more work that we can do, I think, in this area to make a better job of it. So getting back to you, because it's nice to involve you in this talk, which of the following are you think most likely to cause delirium in our patients? And I've got a list of options there. Prescribed medication, metabolic disorders, organ failure, brain metastases, or all of the above? Leave you guys some time to answer that. So most people, 91% said all of the above. I don't know if I made it too easy for you. That's absolutely the right answer. So all of these are commonly causing delirium in our patients. And prescribed medication, it's fear. 7% chose that. And I think that's a fair one to call, because certainly that's one that we see commonly. But certainly all of them are seen commonly. Thanks very much. So yeah, I think I made that too easy. One way that we can, a simple way that we can try to get to identifying this more often is just one very simple question. Do you feel, saying to the patient, their friend or relative, do you feel that he or she has been more confused lately? And actually that's not shown to be bad in terms of sensitivity and specificity. And actually it's got quite a high predictive value. And I guess one of the important things is the lately, because we know that it's for being acutely confused. That's the problem for it. That would point us more in the direction of a delirium. So I'm going to start talking about some cases. This is the first case I'm going to talk about. 68-year-old man, Joe. He had a 6-month history of lung cancer and had lumbar metastases. He was on Emerslon 30 milligrams twice a day and had been for quite a while, and was only occasionally using extra medication. He was also taking a non-steroidal. His bowels were working fine, which is something obviously with the morphine we're always looking out for. He lived with his adult daughter and her family, and actually things were going pretty well for him. Until there was a call on the Friday afternoon when, as we know, we always get calls like this. Joe had his morphine titrated up during the week, actually quite aggressively, because he'd become so distressed, and it was felt that this distress was to do with pain, and because he'd used so many additional PRN medications that had been matched with his long-acting dose, so that he'd gone up from 30 milligrams BD to needing actually 60 as a PRN dose. He'd had poor oral intake. Everyone seemed distressed at home, and the call was from distressed family. The pain continued to be severe. No one seemed to be able to get on top of it. And Joe was now becoming verbally abusive on top of everything else. So really distressed situation on a Friday afternoon. 3 generations were there, his wife, his 2 daughters and grandchildren. And they were talking about him being completely different, angry and argumentative. But going in to see him, actually, he was just appeared quite drowsy and quite pleasant at the time, so comfortable. However, he reported pain all over, and he described the pain as being 10 out of 10. And he thought that his daughter was trying to kill him. So let's find out a bit more. He was oriented to time and to person and place, but not to time. He seemed quite anxious. So the number of things that we kind of feel like we can ask, which give us a bit more of an indication if this person's got a delirium. So we asked him whether he was seeing anything unusual in the room, maybe things that don't belong. And he said he had been seeing his cat. That cat had been dead for 3 years now. The other question that's quite useful is whether people are feeling something on their skin. So that feeling of perception, and they look and it's not there. And he had feelings of crawling on his skin and didn't see anything to account for that. And finally, the other third question that's quite useful is to whether you think someone's in the room that's not there. So now we're trying to get at any visual hallucinations, but he didn't have any of those, and he'd had the first 2, but not the third. The other thing that it's useful to do is do some sort of screening pool. It's not something that we always feel like we want to go through, but actually that gives us quite a bit of information. And his mini ACE, which we did, showed 19 out of 30 of a score. I'll just show you the mini ACE. I'm sure you're all familiar with it. It's the mini Addenbrook's cognitive examination. Although it looks as if it takes some time. Actually, it can be quite quick to administer, really trying to find out about attention, memory, their fluency, and visual spatial identification to see how that is. So that's one that you can use. It's available easily on the net. So examining him, he appeared dehydrated. There was no signs of any infection, no chest infection. He was passing urine okay. He was a bit tender around in the back, but and also he had some myoclonic jerks. So these often we see with people who have got too much opioids on board. So at that stage, it was decided to admit him to hospital, determine any reversible causes for the delirium that we've diagnosed. And in hospital, he was found to be in renal failure. So he had acute renal failure with high creatinine and urea. He had normal calcium and electrolytes, so nothing wrong there. And his urine was normal, didn't have any other infection that was found. So really what had happened is this Joe had gone into acute renal failure. His opioids had been up-titrated very quickly and now had been not excreted normally because of his renal failure. He was rehydrated. He had an opioid switch to oxycodone, which we use in moderate renal failure. And the dose was reduced back to his original dose before it began escalating. So the 30 milligram equivalent of 30 milligrams BD. His renal function improved, and as did his mini-ACE. So he was discharged back home. So I guess there's a number of reflections that I want to bring out from that case. And I guess the first thing is, why did his pain requirements go up initially when he was stabilized on the same amount of opioids? So his pain was controlled when he left hospital on the same amount of opioids, which were about a week before, without any of that up titration. There was probably a number of things. Certainly he was distressed, and we know that distress and delirium means that people describe pain more. So his expression of pain may well have been more related to this than any physical pain. When we went and talked to Joe about what had actually gone on, he also reported that actually at the weekend, his eldest daughter, who'd looked after him for 4 weeks, had to go back to work, and his second daughter had taken over on the Monday. And she was really concerned that he would be out of pain and had a very low threshold for giving him the opioids. And we do find that for some family members, it's a really hard judgment call to make. And when they find they're hypervigilant, if you like, and they're constantly asking somebody if they've got pain, and if they want to manage that straight away with the opioid. And because Joe was therefore in a different mode, he obviously was, for one reason or another, not been eating and drinking as well. We had a degree of renal failure. He was feeling delirious. He was reporting more pain, and then there was a low threshold for giving him more. It's also something to watch out for when somebody is using a lot more extra doses, whether there's another factor than that you should actually immediately put up the background dose, which is something we often do. So it's easy for us also to get confused about delirium and whether make the diagnosis. So one is its fluctuating nature, and you can find this happens in hospitals and in the community too, I guess. That one person goes in to see their patients and says they were fine, and then another one goes in later in the same day, says no, they're actually acutely confused. I think they're delirious. And obviously, that's the very nature of the diagnosis. It's fluctuating. It's different at different times of the day. We also might give medication that we think is going to help. For example, somebody has an agitated or more hyperactive delirium. There's a temptation to prescribe benzodiazepines, and that might be felt to be helping, but actually it might just be that the delirium is fluctuating or hyperactive, and that's not actually doing much at all. It's also easy to label people who've got a hypoactive delirium as something more like a depression or a mood disturbance. And we also make the error of sometimes trying to sort out the pain first, and then we haven't actually sorted out the delirium. So then we get ourselves in a difficult situation there. So just some things to look out for when you're considering or looking at these patients. So distinguishing pain from delirium is quite challenging. It may be easier to look at what the cause of is the pain, and is this pain fitting in with that description or previous history of his pain, or is it more generic? Is the pain relieved by the analgesics or actually not really helped? And can they give a localized history of localized pain, or is it more generalized? These are some of the things to think about when you're trying to distinguish, is this really pain going on, or is there something else here? And just a quick mention of dementia and delirium and the challenge of distinguishing. I think the message is, if we are finding that challenging, and really history going through with a tooth comb, really patient notes is where I find that we get the most help on this. And certainly it's useful information for us when you referred patients to us to really know if they've had any cognitive impairment, even if that's mild. But really the message is, if we treat the delirium first, then we can't cause too much harm in that way. But certainly history is key with dementia patients. They wouldn't normally get the fluctuation. So perhaps the only exception to that might be in a Lewy body dementia. So really history is key here. So the other important thing for us is also education for the family. They can find it quite traumatizing when somebody's agitated, and it might take you a bit of a while to get on top of that agitation, and explanations of the person's state, mental state, why that might be happening, might really help that family. So look, he might have been aggressive to you because he's actually hallucinating and seeing frightening images. It's nothing to do with you or his relationship with you. If you can imagine not being sure of where you are and how that would make you feel. And then there's sort of simple things that they can do to make things more easier to manage a patient who's delirious at home, maybe not having multiple conversations at once, reducing the noise levels and light levels in the home. And also just letting them know that we are there as backup. We do have a 24-hour line at HWA. If they're worried about whether he's got pain or not, or something else is going on, maybe we encourage patients to call us so we can talk things through. So I'm going to move on to the second case now, and I'm going to invite Charlie to join us for this case, as she knew this patient well. Welcome, Charlie. I'm just going to go through the case, and then I'll ask Charlie to any reflections that she might have, or she might want to interrupt, which is fine. Also, Charlie, if you've got something that you wanted to add. So Marianne was a 32-year-old woman with metastatic breast cancer to the liver and spine. She had before this occasion that I'm talking about, she'd had an admission in which she was treated for hypercalcemia. She'd had a recent up titration in her medication. She was on methadone for pain, which I think was just because that was the drug of choice for her in terms of managing her pain. Am I right there, Charlie?
Yeah, she hadn't been doing very well on other opiates and morphine and oxycodone, so methadone seemed to be the thing that did work better for her. Okay, great. So she was on methadone, and now she was complaining of nausea and also severe drowsiness. Marianne's family were complaining that she was very drowsy. She was visited at home by 2 members of our team, and they noted that a recent CT had shown progressive disease with large volume liver mets and some bony disease. When at the visit, she had some myoclonic activity, but no other clinical findings, and she was felt to maybe either have an opioid toxicity or hypercalcemia. Did you want to add anything there, Charlie? Yeah, I think the myoclonic activity was probably our first thought, and I think initially that's why she was switched to methadone, because we felt that she was having side effects from morphine and then oxycodone. So yeah, it was difficult to kind of differentiate between what was maybe toxicity and what was the hypercalcemia. Yeah, so that's a common thing we find, is really trying to find out what the underlying problem is, especially when you're working in the community and someone may or may not want to be
admitted to hospital.
And she had young children at home, 3 young children under 12, I think, and her focus really was on being at home. Didn't like going to hospital. And also I think her understanding of things such as hypocalcemia. I think hypocalcemia is one of those things that people don't really realize how serious it is. You know, it just sounds like something that I can take a tablet for and that'll be fine. Actually, it was a lot of trying to educate her and her family about what this means and sort of prognostically what that might mean for her as well.
Yeah, I think that's a really good point. So for our patients, once they get to a refractory hypocalcemia, and often early in the disease, we can manage hypocalcemia, but as things progress, it becomes more refractory, and we find some patients really aren't responding well to the bisphosphonates and rehydration, if that's an option. And actually the time that they need, becomes reduced, where they need their calcium pops back up again. I think that was so in Marianne's case.
It was. And I think the other difficulty we had was we'd organise sort of urgent home blood test visits, and I think perhaps on our part we didn't sort of impart how important it was that she gets those, and then she'd be out or she'd miss blood tests and things, so it would delay us being able to diagnose what was going on.
Yeah, I think that was definitely a factor in this case. So we did organise bloods in the home, and at that time the calcium came back at 3.5. So she was admitted again to hospital, this time to manage it, and she was given zoledronic acid and IV fluids. We also reduced her pregabalin. Sometimes we find that the combination of methadone and pregabalin can cause problems with drowsiness as well. And pregabalin toxicity itself, if that dose is high, can give myoclonic jerks as well. So something else to look out for. So we did reduce that as well. And she did seem to stabilize and become less drowsy. Unfortunately, though, that didn't last. And she was really at this stage of what we see, a refractory hypocalcemia, where it really is about having conversations now about prognosis being short because of that hypocalcemia. And I know that this is really challenging, especially in our younger patients. And I think she was already still on treatment. Is that right, Charlie?
Yeah, she was still on oral capecitabine.
So that makes it equally challenging. And in mother of young kids, her mother as well around. It's a really hard conversation to have with people, and for people to understand that this might be a life-limiting event. So once we found that her calcium had risen, we had planned actually to give, because we've started giving zoledronic acid in the home if people don't want to go into hospital. So we can provide that as an option. But unfortunately, before we could do that, she had a fall and ended up via hospital, getting admitted to hospital and dying there. So I guess part of the reason that I brought this case forward is that actually, were we looking at a hypoactive delirium in this case? And I think it's, in some ways, it's academic, but also it's another way of us thinking about how we treat and manage people, which might be important to pick up. So I think the key feature that she had that would be common in a hyperactive delirium is really that drowsiness and unusually sleepy, unable to stay focused when awake. I don't know what you thought, Charlie, looking back on this case.
Yeah, I think she was awfully drowsy. I think that the challenge in her house was it was very difficult to sort of get a history of how things had been sort of, the previous day or so. And it's difficult in the community because you're not seeing people 24/7. And the house was quite chaotic. And she wasn't someone who engaged overly well anyway. But yeah, definitely you would sort of be talking to her and she'd just drop off to sleep and wake up and sort of not be really aware that she had fallen asleep and wasn't aware of the conversation. So yeah, she definitely displayed, I would say, all of those symptoms, to be honest.
And I mean, obviously, drowsiness is also common with hypercalcemia, so it's a really difficult thing to tease out. But it is the most missed type of delirium. It's something for us to think about. There's often a slowing or lack of movement, not much speech without prompting. a person might be kind of less responsive. They might say yes a lot and smile and appear to be engaged, but on closer questioning, I think some of the key questions are quite useful in terms of finding out if there is anything else going on. I don't know how that, any additional comments from you there, Charlie?
Yeah, I think sort of just reflecting on it, I think probably the main focus had been on the opiates. And actually, I do think she did have that hypoactive delirium. And I think that really impacted on her final weeks because she wasn't really able to engage with her family and spend time with her children. So yeah, I think that had sort of had a negative effect on what her sort of end of life care was like, really. And it's interesting when you say that people with delirium can sort of describe pain more, because pain, that was sort of the vicious cycle I think we got into initially with her, that the pain was really awful, and that was attributable to the advanced disease she had, and her disease was sort of racing away from her even though she was on treatment. So we would sort of up titrate things, and actually it might have been more some of this delirium, and I think, as you say, the distress around things as well, her sort of psychological distress with things. She was very young. No one, you know, in terms of oncology, she was still having treatment, so this was all changing really fast for her, and I think that did have an impact on this delirium.
I think these things are really, really hard to look at, and thanks for that reflection. I think it's so important for us to share, you know, how we think about things looking back. I think that we work really hard with this. I know that you guys work really hard with this family. I think managing young patients, which we seem to be doing more and more, or I get that impression at the moment, especially when they're having ongoing treatment. Clearly, there's not much, a lot of our patients, those patients, it's challenging to talk with about when things aren't going to work out well. And sometimes they really don't want to have that conversation at all. Thanks very much, Charlie, for sharing with us.
I was just going to say, I think with her also, it was difficult to have any conversations really, because she was so drowsy and sort of sleepy for such a long time that we almost missed that opportunity. Once that started, she never sort of really recovered from that, I don't think. She might have had days here or there where she was a bit better, but yeah, it sort of prevented us from being able to have bigger conversations about her future care.
And that may well have been part of the signal that her disease was progressing despite what we were doing. Okay, thanks very much, Charlie.
Thanks.
So I just wanted to check how often people have wondered about the diagnosis of a hyperactive delirium in their own patient, whether you frequently thought about it, occasionally, rarely, or never. Those of you who are on the phone or something, just have a think in your own head how you'd answer the question. So people tend to think about it occasionally, and I think I would say myself, I don't think about it enough, definitely. And I think just even doing this presentation has reminded me that I need to think about it more often. Thanks for that. The other one that you may have heard of is the confusion assessment method. I'm sure you can find that easily, and you've probably been to talks where people have talked about that. That's basically a translation for us of the DSM diagnosis into questions for ourselves. You know, is this patient got an acute onset of mental status change with a fluctuating course? Are they seeming to be easily distracted? Can't keep focused on what's going on? Is their thinking a bit more rambling, switching, not that logical? And do they have an altered level of consciousness? So there's this confusion assessment method, which I think is also promoted by the GP College, is quite a useful way of diagnosing or screening for a delirium. So I think we've all, so that was my key message, that it's easy to miss this. And also just bringing out that case of often people talk about someone's confused and maybe they're pleasantly confused, but actually that's not that pleasant. People who remember a hyperactive delirium also remember that as traumatic as well. So it's not something to, they're confused and we're pleasant about it, is how one person put it. So I'm clearly time's getting hard, so I'm going to push on here. Can we prevent delirium? Yes, no, some of the time, most of the time. Any thoughts there? I think some of the time, most people would agree that some of the time, 76% said that, and I think I'd agree with that, although it might be more of the time than we think. I think that we often don't think about preventing delirium, but actually thinking about those who are high risk. Many of our patients are, making sure that we are getting their bowels working, that there's no urinary problems, that they get adequate sleep, that we are actually proactively trying to check their electrolytes. We might want to use a screening tool for early detection if they're high risk. So there are some things that we can do. And there are some hospitals, especially in the States, which have very active management of, prevention of dementia, delirium programs when people arrive in hospital, which identify those at risk and seek to prevent a delirium occurring. So the third case I'm going to talk about is Annette, and I'm going to ask Shannon to join me for this case. Hi, Shannon, welcome. So Annette was a 45-year-old woman. She lived with her mother and son, and I think her father, is that right, Shannon?
Stepfather, yeah.
Stepfather, yeah. She was diagnosed with metastatic breast cancer in 2020, and unfortunately that recurred this year, and she was found to have brain mets. Actually, we knew the family because her grandmother had died the year before under our care. Annette had gone on to get leptomeningeal disease and had got seizures which had become difficult to control. And that was when I first met her in hospital, when she was using a combination of anti-epileptic medications. However, she was deteriorating. She was finding it hard to swallow, and she had to be changed to a syringe driver. Luckily now we can use levetiracetam, which she was on orally as a subcut medication, and we often now use that as well as benzodiazepines to manage seizures or prevent seizures when someone's switching to a syringe driver. She hated hospital and only wanted to be at home, but her mother was extremely anxious, especially about the possibility of seizures and other problems. And we knew her from previous times, and have to say that our out-of-hours service and both you, Shannon, and I know our healthcare assistant were known to the mum, and that really helped in terms of her accepting our service. Those people had been able to support her and her anxiety levels in the past. So one evening I had a call because Annette had become very agitated and extremely restless. When I arrived, she was certainly moving about the bed, seemed very distressed. She described having visual hallucinations, generally of people she knew, and in particular her father, who had died, and she didn't feel at all comfortable with those hallucinations and really wanted to be more relaxed. There wasn't really any signs that she had opioid toxicity. In fact, there'd been no increase in her opioids recently. They'd been pretty stable. Her pain had been pretty well controlled, and she didn't have any sign of seizure activity. Mum was really distressed, and her daughter had been like that for a while. She hadn't actually called us this time, which was unusual for her. But she'd really been like that for a good 12 to 18 hours. So what do you think? I'm not going to take this to a poll because I think we're running a bit short of time. But I guess our options are what to think would be the best person for the patient. And in this case, they really wanted to be at home. And so the importance for us was to keep Annette at home and do what we needed to do to enable that to happen. So she was diagnosed with a terminal agitated delirium because we knew that the time frame was right for this. She was deteriorating and probably likely to have days left. Her mum was really uncomfortable with how she was, and Annette could speak to us briefly to say that she would also like to be more sleepy rather than to be restless as she was. Actually, it took quite a lot to manage her restlessness. We often use levomepromazine when agitations are quite severe at the end of life. and I had to give her 2 doses of 25 milligrams of Mozonan and 10 of midazolam to even actually settle her. But then she settled, and we were able to put doses in the pump, which, as described here, she had 50 milligrams of levo, midaz 50 in the pump, and her usual dose of oxycodone, which I think had only been titrated up a minimal amount. So that made things easier in terms of making the diagnosis and knowing what was going on. Shannon, do you want to talk a bit about your experience with Annette and her mum and the family?
Yeah, sure. So our relationship with the mum, Susan, about a year ago, her mother had end-stage respiratory disease, and basically was discharged home for terminal cares. So it was a space of a day that I went in the morning, did initial assessment. Our healthcare assistant went in the afternoon and gave her more support, and then Celia was called in overnight to give her some more, because I arranged PRN medicines via the GP, and they didn't quite prescribe enough doses. So we had this quite intense, short, sharp, supportive encounter with them. And the mother had died that night, so that was that. So Annette went into hospital. She'd been working recently. We had no contact with her before hospital, and hospital was pretty traumatic. Mum was tired. She'd had run-ins with the staff. So Celia sort of optimized her medicines, took care of her seizures. She never had another seizure that we know of after she came home. But when they came home, they were very tired, but very determined. She came home and she was constipated. I think they'd tried to address that in hospital, but it had all just been a bit difficult. She wasn't taking tablets. Being someone who'd never worn nappies before, I think asking someone to start having bowels open into a nappy is difficult. So there's awareness there that that's not the right thing to do. So that all leads to constipation. So we dealt with that on our first day to some degree of success, I think. She was able to say how she felt, Annette, but it was worse at night, and that's where the after hours team came in and really supported well. A lot of anxiety. Mum had good instincts on how to deal with her and what to give her, but she got easily confused about things.
Yeah, so I think there's a lot of input for this family in the last week of Annette's life, and I think that was really important, and it was lovely to be able to make sure that we were able to keep them at home, which is what Annette had wanted.
Yeah, I think, you've got an obvious cause of delirium, but then you've got to have other factors that come into that. And we did bowel work a few times for her.
Yeah.
Which I think, it wasn't going to solve anything, but it definitely helped her comfort level.
Yeah, no, that would definitely be, and that's, as we've just talked about, one of the ways of preventing a delirium, by making sure we've got those things working properly, and really important for our patients. Thanks very much, Shannon. So I guess also just wanted to mention, and Shannon, you're welcome to comment on this as well, that there's also non-pharmacological management. And certainly when I went round to the house at that, it was quite late at night, maybe 9 at night. It was interesting to note that the TV, which was quite big in the room space was quite small, and the TV was quite large, was on and quite loud. And I did talk to Mum about just creating the space a bit more quieter, maybe turning down the lighting. She turned off the TV, and it's just about giving those really simple advice to try to make things a little bit calmer in the space.
Yeah, that's interesting, because the TV was never on in the daytime when we visited. There were usually a few people in the house, but I think you've got to weigh up that with Mum needed the support of her friends, and and that was necessary. And
Yeah.
people were quite good. They'd sit right beside her and quietly talk, and other people would sort of go outside and have their chats outside while that occurred. So there's a lot of that behaviour that was really good. Annette had a 14-year-old son, so we were mindful of him as well and how he wanted to approach it. Sort of had to give him his space with that. But Mum was hard of hearing, so that was possibly why the TV was so loud.
I wonder as well, it was a way of managing her own anxiety and stress, because I think she found the situation stressful, and once Annette was settled, it was fine, but she probably was managing that as well, to be honest, in terms of distraction.
Trying to encourage her to go and have a nap when Annette was settled, go and have a sleep. That was really quite a challenge for her to try and do.
Yeah. Okay, thanks.
But as we know, when you're tired, everything's harder to deal with.
Yeah. So effectively what we had in that situation was irreversible delirium. And obviously for us in these situations, how we manage that is also negotiation, because some families have different cultural attitudes and beliefs around, especially around drugs and medication. And so usually clarifying what we're doing and why, and involving family in the decisions is really important at this time. Most frequently used approach is a combination of the opioids, benzodiazepines, and antipsychotic. And currently the antipsychotic most commonly used is paraparadol as first line and levomethadone as second line. I would say that may be changing as the use of more atypical antipsychotics is being considered. And it's also useful for us sometimes to actually monitor the sedation. And this is just one scale that we can use to do that. So there are ongoing controversies in management of delirium in palliative care at the moment. And I'm just going to very quickly give you a few-minute run through what those controversies are, but I can't have time to go into those in depth. I think there's been recent studies that questioned the role of haloperidol, is particularly in mild to moderate delirium, and whether it was actually making a difference. And this study showed that compared to placebo, it didn't make a difference. And in fact, there was more side effects in the risperidone and haloperidol treated group. There's some debate about the study, and we're still waiting for more randomized trials to replicate that. So the role of antipsychotics is, atypical antipsychotics is being debated, and often the reason that we chose that haloperidol and levomethadone have been used is their ability to be subcut, but olanzapine is now being used subcut, and certainly I've used that quite effectively. It can be used in a driver, but on its own, but also as a BD subcut dosing. And quetiapine, which I know many of you GPs will be using infrequently, is something that we're starting to see used more in palliative care. The role of benzodiazepines and doses will often be hotly debated amongst palliative care physicians, but I guess it's all about starting low and going slowly and using the minimum dose that we need to manage the situation. And also the role of newer non-antipsychotic, non-benzodiazepines like dexmedetomidine, for example, which is being used now in palliative medicine. So although we haven't got a huge amount of time for panel discussion today, we will reflect on your questions and get back to you in an email. But I'd just like Charlie and Shannon to join me again just for any final comments or points that they would like to make. Shannon, I know you had a lot of experience in hospital managing these sorts of acute deliriums. I don't know whether you had some.
Yeah, I was in the team of a security guard and nurses that sort of code orange, if you're familiar with that. But we would manage the acute aggressive delirium. Often that came down to who was looking after them. with a person who's delirious, you have a ability to calm and de-escalate, or, you know, sometimes the way people interact elevates everything. So never argue with the delirious person. In my experience, it never works. Never growl at them, because they remember how they were treated. They don't tend to respond well to being growled at. So be kind, be, you know, gentle and directive, and then you might have to use your medicines as well. But that's my experience of dealing with this sort of aggressive kind of deliriums. There was a question about environment. How do you deal with a huge, big family environment that's loud? And well, that person existed in that environment, so to some degree that's going to be familiar to them. So you kind of have to play it by ear. Families need support as much as the patients do. You can give advice, but a family is going to do what they're going to do.
Oh, sorry. I was just going to say that I think recently I've had a few patients who have been delirious due to hyponatremia. And that seems to be something we see quite a bit of. And I think sometimes it's quite easy with a delirium to think, well, this is a delirium and this is just sort of part and parcel of how things are going for them. And I guess with investigating delirium, it's knowing what we would do with those results if they were abnormal. Would someone actually want it treated? If they're not going to, then I suppose investigating it isn't appropriate. But definitely thinking around what are the causes, are there things we can do to reverse it rather than just treat it, I think is important.
Yeah, and I think we have a great home blood test service in Auckland, and we also have a great we can access mobile x-rays as well, and both of those have been really useful to us in some of those determining what's going on. I see there is a question, really interesting question about your thoughts on delirium versus deathbed visions. And that's a really interesting question. I think really it's about the whole picture, and it's about the whole of what's going on. So often we do hear people, we do experience people talking about they're seeing people that may have died that they knew well, maybe loved ones that have passed that they're thinking about, or and they talk about seeing those people, but that might be an isolated thing, and otherwise their mental state is fine. The conversation, you know, there's not the inattention or the drowsiness or the aggression that goes with a delirium. So I think when it's isolated, I think we would see that very much more as what you describe as deathbed visions. But if it's delirium, then there's something else. But Charlie, you had a comment. Did you have a comment to add to that?
No, but I'm of the school of thinking of when people start seeing these things, I think, oh, actually, that is an indication that things are changing, just because of I guess there's no sort of specific data on that or trial, you know, research on that. But in my experience, when people start to say, oh, you know, mum's talking to me, she's been dead 10 years, or I can see mum calling me, often then things are sort of happening in the next little while. So it can be a good indicator for us. And often I say to families, oh, you know, now might be the time that we start to think about getting people in to see dad or whoever, because he's sort of saying these things, and they seem to be quite a good indicator of time.
Thanks, Charlie. I think that's a lovely way to end our discussion today. Thanks so much for joining us, everybody. We look forward to hearing you, seeing you again at our next webinar. And yeah, thanks again.